Hello, everybody. Welcome to this session about emotional harm and microaggressions in the healthcare system for LGBTI plus people. My name is Jens Revnlov. I'm a senior advisor from the Danish Society for Patient Safety, and I will facilitate this session today with Ove Gorbo and Dr. Kamila Kamarudin. The session today is emotional harm in healthcare. How can we create an emotionally safe healthcare system for LGBTI people? And here are the hashtags for today's session. You are included and emotional harm. For the past 2 years, the Danish Society for Patient Safety has worked with emotional harm. And for the past 6 months, we have been working with emotional harm and how we can create an emotional safe healthcare system for LGBTI persons. We have worked together with LGBT plus Denmark and also with Dr. Kamila Kamarudin, who is on the session today. And this is really what we want to talk about today. But with me today, I have Ove Gorbo and Kamila, and will you just introduce yourself? Ove, you can begin.
Yes, thank you, Jens. I'm happy to be here at this conference, and my name is Ove Gorbo, and I'm a medical doctor, and I'm a senior advisor in the Danish Society for Patient Safety, and I have been working here for the last 6 years. And before that, I was head of emergency medical department in another part of the country. Thank you.
Thank you, Ove. And Camilla, will you introduce yourself?
Yeah, good morning. Hi, my name is Dr. Kamila Kamarudin, and I am a GP in London. And I'm also working at gender identity clinics in London as well. I am a member of the Royal College of GPs, the LGBT plus steering group committee, and I have won awards, namely RCGP Inspire Award 2019 and Frontline Hero Awards 2020.
Thank you very much. Now we will just present today's agenda. We have 45 minutes, and we will just talk a little bit about the background for the session and present the concept of emotional harm and microaggressions. Then you, Camilla, will tell your story and your experiences with emotional harm and microaggressions and its consequences. And then at the end, we will have a facilitated discussion. What can we do to prevent emotional harm and microaggression? Yes. But I will just tell you a little bit about the Danish Society for Patient Safety's history with emotional harm, and really our journey began when we traveled to Beth Israel Hospital in Boston, where we had a session with Patricia Folcarelli and Lauke Sokol-Hessner, who worked systematically with emotional harm. Typically, the patient safety movement has focused primarily on physical injury, but they focused on emotional injury. And their perspective was really, and our perspective is really also, that the definition of harm should be much broader than only to physical injury. Yeah, and they, Beth Israel, they conceptualized harms, emotional harm, as harms to a patient's dignity by a failure to demonstrate adequate respect for the patient as a person. Yeah, and I really just have some examples to illustrate this. And the first one is actually from Lauke and Patricia's own article about emotional harm. And I just want to read this. A transgender woman patient is addressed as Mr. at the reception desk. When she corrects the staff, she witnesses them giggle and roll their eyes. The second one we have is from a Danish newspaper, and this is from René Sommer, who is mother to Andreas Sommer. Andreas was and is ready to cry every time someone calls him she in connection with doctor visits. The worst thing for him is when people do not even try. Yeah, we just think that these examples illustrates that emotional harm is a very important concept, and it can really damage a patient's trust to the healthcare system, it's important to have trust in the healthcare system, because if we don't have trust in the healthcare system, we will not contact the healthcare system, for instance, if we have sickness or other healthcare issues.
Thank you, Jens. Why is emotional harm a problem? It's a problem. When I worked as a senior doctor in emergency medical department, we had, of course, such a place you have a lot of complaints. You have complaints, and I was in charge of looking at the complaints, and 95% of the complaints were about emotions, not about the treatment, not about the medical treatment, but about emotions, when people were not treated with respect, dignity, when they were not seen, and they were not listened to. And that's interesting, and that's also interesting in this aspect. And emotional harm is a big problem, because it can have long-term consequences, because the patient doesn't trust the system anymore. So it affects the patient views and attitudes towards healthcare. And it extends beyond the patients, because they tell the family and friends, and everybody's talking about how bad it is to visit this emergency department. So we can we can prevent it, and we can only prevent it if we are systematic, in the same way as we are when we are talking about physical harm. Next slide, please, Jens. There's research that shows that although LGBT people are often less healthy than the wider population, they receive lower levels of care than non-LGBT people, and they also tend to seek care less than non-LGBT people. So the inequality expands as it goes, like a spiral. The LGBT people need to be treated equally, but not identical to, of course, other groups. But there's not enough understanding from service providers of the different needs that LGBT people have. In Denmark, we have 2019 a very nice report from Ede, Fouchard, Frisch, and Draugård about Danish LGBT people's encounter with general practice. And it's a very nice report that shows that fear of being met with prejudges and discrimination results in LGBT plus people being reluctant to talk about sexuality or gender identity with a doctor. And of course, there's a big problem. So we think that emotional harm can contribute to inequality and equal access to health. Everyone must be treated properly and with dignity and respect, and be able to trust the system. Next slide, please, Jens. Yeah, and how are we working with it? We are not experts, and we have not been working for years and years with this, but we have established collaboration with LGBT Denmark. We participate in debates everywhere we are invited about the LGBT plus communities meeting with general practice. We're trying to broaden this knowledge in the Danish healthcare system, raising awareness about emotional harm. Our communication is one of our specialties, I will say. So we have a lot of listeners and viewers. So we are encouraging the health system to test new practices and to collect the data about this. Next slide, please. Yeah, and we have not a very filled up safety toolbox in this matter, but in the system perspective, we can say that if mistakes and emotional harm occur to people, then we must work systematically to prevent them from happening again. It could be in like reporting adverse events, also in these matters, not only in physical harm. So it requires awareness, data testing, and we have to involve citizens in if we have to improve in these matters. Our ambition is to have a system that gathers knowledge, experiences, and unintended events from emotional damage to ensure systemic learning. And in the long run, we want to create a more inclusive healthcare system in general, where we can prevent emotional damage for all patient groups. Thank you.
Hello, my name is Dr. Kamina Kamarudin, and I am a trans GP working in London. I advocate for intersectionality as a trans person, as a woman, as an immigrant, as people of color, and sometimes as a Muslim. I left Malaysia in the 90s because it was not possible for me to be who I am back in Malaysia. Trans identity is denied in Malaysia. There is no access to higher education, no access to healthcare, and there is blatant discrimination from the authorities. Although I feel much safer in my adopted country, the UK, guilt and sadness will always be an exile's companion. My journey as a trans person is long and fraught with bouts of depression, low self-esteem, and bad coping mechanisms. There was probably too much drinking in the past, and even until now, I am still ashamed of some of my behavior then. But I was not in a good place then. I was unhappy, I was depressed, I was vulnerable, and worst of all, I do not know how to reach out for help. And I am truly pleased that those days are now over. And I can also vividly remember there was one incident that made me, it was a turning point in my life. I wasn't sleeping well then. And one day I was driving to work and I fell asleep at the wheels and it nearly caused a nasty accident. And I said to myself, I have to do something about it. I I was alone on a cold morning day on a highway in North England, and I was in tears. And I said, if I don't do something about my life, I might not be so lucky the next time. It took me many years then to be able to transition. I announced my intention to transition at my GP practice. My staff were very happy for me. They gave me a round of applause and uh, they congratulated me. They only asked me one question: what and how should we tell our patients? I can understand the anxiety. If our patients do not accept my new identity, it will be very difficult for all of us. And there were no guidelines for staff or GPs to transition at a GP practice. So basically, I had to make the guidelines myself out. And I told my staff, let me tell the patients myself because I wouldn't want the burden of informing the patients would be on my staff. So I said to my staff, I will tell the patients myself. I took a short break and came back as Dr. Kamila Kamaluddin. The first day was a nerve-wracking experience. Put on a big smile, new dress, and says, hi. My staff were very happy. They congratulated me. One of the regular GPs couldn't recognize me and thought that I was a new female GP. Some patients asked me, oh, are you the wife of Dr. Kamaruddin? Some male patients even flirted with me, and but most patients are the regular patients, they're very happy. They congratulated me, they even hugged me, gave me nice presents, and wrote some little nice cards. And the new patients who do not know who I was before couldn't care less. As long as I, treat them well, they're very happy. So it reminded me that as a doctor, it doesn't matter what your gender is, as long as you're a good doctor and as long as you provide a good care. I think that's most important for a patient. My practice sits in a locality with a lot of very conservative patients. The women wear long dresses and cover their heads. When I was a male GP, it was almost impossible to examine them. A chest examination was a struggle. And after my transition, and even knowing that I have transitioned, these female patients, allow me to examine them, even the intimate examinations, and refuse the offer of a chaperone. I was very happy about that. It was such an emotional experience for me. And I soon realized that acceptance is an uplifting experience for those who are doing accepting and for those who are being accepted. My experience with General Medical Council, it was very disappointing. The General Medical Council did not follow the guidelines and did not register my new identity properly. So after 2 weeks, they called me and says, "Oh no, you cannot continue working as Dr. Kamila Kamaluddin." I was quite upset with them, and I felt that my own professional body has really let me down. It was very disappointing, and I didn't get angry. I asked for compensation, and they duly paid. So it's better that way to ask them for compensation as a way that they admitted that they had done an error. And my experience as a patient, it took me 3 years to be 3 years of waiting to be seen at the gender identity clinic. And it was not after a year later that I could start hormone therapy. And then my GP refused to continue prescribing a hormone treatment under the shared care guidelines of the gender identity clinic. I was really upset with them. So I changed GP, and my new GP was very much kinder, much more friendly, and they continued prescribing. And even until now, they continue prescribing my hormonal treatment. But 2 weeks later, one of the admin staff rang me and said that I am due for a mental health review. I was quite shocked. And then I told my GP, I don't have any mental health illness. I don't need to come for mental health review. And I told them that trans people are not necessary to have mental illness. Being trans is not a mental illness. And they apologized, and I'm very happy that they are willing to learn from their mistakes. I am very grateful to my adopted country, to the UK, and to the National Health Service for giving me the opportunity to thrive. We in the NHS, people from different backgrounds, race, religion, color, uh, gender, sexuality, we all work together and in harmony. And I am very, very privileged to work in an organization like the National Health Service. And also, I have stopped being angry at the perceived injustices against me. And when I stopped becoming angry, I was able to see things in a bigger picture, and I began to advocate for a better healthcare for trans people. And I would like to share uh, some statistics about about trans health in the UK. This is Stonewall's LGBT in Britain Health Report in 2018. 37% of trans people avoided healthcare. 16% are being denied healthcare because of their gender identity. 46% have suicidal thoughts in the last year. 12% have attempted suicide. 67% have experienced depression in the last year. 71% have experienced anxiety symptoms. 41% of non-binary people say they have harmed themselves. 20% of trans people have witnessed discriminatory remarks against LGBT by healthcare staff. And this shows that the damaging effect of emotional harm to trans people. And let's try to understand the barriers to healthcare for trans people if we can make any changes. There are lack of providers with expertise in trans health and hormonal therapy, creating a long waiting list. In England, average waiting time is 3 to 4 years, and there are 20,000 people at the moment waiting to be seen at GIC. This is just unacceptable. Lack of competence and understanding of specific trans health needs when assessing general healthcare services. Let's talk about the barriers to healthcare for trans people. The lack of providers with expertise in trans health and hormonal therapy, creating a long waiting list. In England, average waiting time is 3 to 4 years, and there are 20,000 people waiting to be seen at gender identity clinics. These long waiting lists are just simply not acceptable. Lack of competence and understanding of specific trans health needs when assessing general healthcare services. There are also health system barriers, the inadequate coding system in electronic records. We simply could not define and who are the trans people in our healthcare. And without data, half trans people do not exist. There is just simply no way to do trans status monitoring at the moment. And there are also non-inclusive clinic facilities. The lab references are still very binary, and the request forms are also still very binary. And there's this trans core syndrome, where clinicians views gender as more important than representing medical complaints. It is as if everything that trans people complain about their physical health is all due to their hormonal treatment or to their gender, rather than some other physical illness. Trans health is not taught in medical education, and there are socioeconomic barriers, travel expenses, high prevalence of mental health problems, and many trans patients, trans people have low income jobs. Lack of awareness among trans people, the specific trans health services available, previous negative experience from a healthcare professional, and trans people avoiding medical care for fear of being mistreated. And there's this new concept of microaggressions. And what are microaggressions? They are everyday slights, indignities, put downs, and insults that people from a marginalized group experience in their day-to-day interactions with people. Microaggressions are specific to a marginalized group that's discriminated against. They happen casually, frequently, and often without harm intended in everyday life, but can cause physical and mental health problems. Yes, microaggressions can cause a lot of emotional harm. So, before that, there are some specific examples of microaggressions, and these examples are quoted by trans people themselves. Can't you just be gay? These are people who just do not understand what is the difference between sexuality and gender. I always say it in simple terms. Sexuality is someone that you go to bed with, and gender is someone who you go to bed as. It's quite simple as that. And you dress like a drag queen. And can I touch your breast? Trans feminine patients have always been asked that questions after having a breast augmentation. It is just a phase, dismissing that that gender is something that who we are. And why do you want to change your sex and become unhappy? But a lot of many trans patients, when they change their gender, they are very happy. They become much happier in their life. Their well-being is much improved. And so tell me, did you have surgery? It is also questions often being asked trans people, and it's very intrusive. And you do not look trans. What do trans look like? And you look so convincing. I would never tell that you are trans. This is quite an insult sometimes, in my opinion. And so lastly, how could we do better? And how can we make positive changes? Yes, we can make some positive changes within the system, within the people, and the environment. And these are the questions that we could discuss in the breakout rooms and also in my conversation with my colleagues from Denmark. And I hand it over back to my colleagues from Denmark.
Thank you, Kamila, for an excellent presentation. But you really raised the question, and I think we should, discuss that a little bit. So how can we prevent emotional harm and microaggressions, and how can we create a more respectful healthcare system? And I really want to ask you first, Kamila. You already pointed out some initiatives, but what do you think it takes? Of course, it's a big question, but do you have some suggestions?
Oh yes, I mean there's so many things that we can do. I can talk for an hour about it, but I'll just be concise and try to address the main things that could make some really positive changes. Trans people suffer from discrimination on a greater scale than cisgender people in the areas of employment as well. So trans people in the workplace are more likely to face harassment from co-workers and denied promotion. Many have to change jobs to work as in low-level employment. Uh, so we must have anti-discrimination laws. Anti-discrimination laws must be in place that prohibits discrimination on the basis of gender. Employers should create a more inclusive policies and avoid transphobic bullying, discrimination, and harassment, and policies to provide staff training as well. And back to the healthcare. In a healthcare setting, we must provide education and awareness training for health professionals. Health professionals will need to be ready and able to welcome, include, and support trans people. Trans people already suffer significant health inequalities, and healthcare professionals must be able to provide a sensitive and a comprehensive care for trans people. Health institutions, governments, and health insurance companies must provide more resources for healthcare for trans people. They must provide adequate care for trans people. And trans people need medical support in relation to hormonal therapy, surgical treatment, and emotional harm. There are important psychological needs in relation to gender incongruence, uh, comorbidities, internalized transphobia, prejudice, discrimination, and microaggressions. And be mindful that the willingness to learn and humility from a healthcare professional can be an enormous support for trans people. So I hope healthcare professionals do not forget this. And there's about trans children as well. Trans children reported alarming rates of harassment, physical and sexual assault, mistreatment in schools, contributing to high levels of emotional harm and even suicide. So teachers, parents, school authorities, local authorities, governments must have policies to provide support to ensure that this do not happen to trans children. And about legal system, trans people face a legal system in many countries that often do not protect them from discrimination based on gender. Many countries still do not recognize trans identity, and referring trans people from uh, carrying their and carrying their names and gender markers, from changing their names to gender markers on official documents. Without proper identification, trans people cannot function in society. Many lawmakers, politicians, and religious groups leverage anti-trans sentiments to score some cheap political points. All this simply must stop. Legal system must change to remedy those disparities and ensure that trans rights are protected. And you also have the police system. Police forces should have adequate training and awareness to ensure they can identify and record transphobic crimes. They could better support victims and bring perpetrators to justice. Sadly and unfortunately, we still see in many countries that the police themselves are the perpetrators of hate crimes against trans people. Yeah, yes, this again, all this must stop. Thank you.
Thank you, Camilla. It seems like there is a lot to be done, but Ove, if you are a medical doctor as Camilla, and if you put on the patient safety glasses, so what initiatives would you recommend, like here and now recommendations?
Yes, thank you. Thank you for Camilla for your speech and now your extra speech here about and you focused on the trans people, and I think that's that also is where aggressions is the worst and where the situation is the worst. But I even that I would like to broaden the perspective to LGBT plus in general. And I think it's very important in healthcare that we always say we need more education, and we really need more education, more knowledge. Ordinary healthcare professionals, every healthcare professional must know something about people not having the same sexuality as themselves, and that's a very important issue, and we have to treat with that we also are treating emotions, and we are treating people in emotionally uh, tough situations. So we have to be very open and very open-minded, and we have to ask very open questions, not the closed questions as I know who you are and what you think and how you go to sleep every night because I think I know. You have to be more open, and that's also one of the conclusions. This very nice report that I told about before. So that is what we have to do, and it's not as easy as that, but there's nothing else to do than getting started. And I think debates like these should be broadened to all general practitioners in Denmark. And I think next time we have education days for general practitioners every year. They were cancelled because of Corona this year, but they're coming back, I hope. And there are courses on very many different topics, and I'm sure that next time there will be 1 or 2 or 3 or 4 sessions about these matters. And I hope, I'm sure that this could be a start. And so that's very fundamentally what we have to do. But as every doctor, we have to treat every person with respect and dignity, and we have to work with emotions. Doctors generally may not be as good in that questions. I have the last 2 or 3 years I've been working a lot with end of life care, and a lot of doctors are not they're not safe they don't think they're safe when they're talking about death and the end of life. And that should, there's an old saying, there's two taboos. This is death and sexuality, and I think it's correct in many ways. But you have to be open-minded, and you have to be emotional, and you have to think of your patient's emotions beside what is the problem that was starting the consultation. Thank you.
Thank you, Uwe, for the remarks and the comments. We are closing, we are nearing the end of our session. So I really wanted to hear about some closing remarks from the two of you. We of course have the online live session in August with everybody where we can talk further on this important subject. But do you have any closing remarks, Kamina?
Yes, I plead to all of you out here to embrace trans people, open up your hearts and minds, and invite trans people to your safe spaces, and create opportunities for trans people to thrive. And at the end of the webinar, if you could make a pledge, however big or small, to provide more inclusivity for trans people, I would be very grateful if you can do that. Trans people are good people, they are hardworking people, and they want to contribute to the society. All they need is opportunities. Thank you.
Thank you.
Thank you. And that was a beauty. we should stop there. But I would like to say that we have this great system in Denmark and in other countries too about reporting adverse events. And it could be an idea to say that the next year we try to we try to encourage healthcare professionals to report also emotional harm events. We put the posters up in the hospitals where say, as a patient, you must report if you feel emotional harm, and you have to report microaggressions, and we have to collect those data and work with it. I think we could have a very big eye opener. So that's very traditional proposal I have here, but it is working with old tools in new ways. So report microaggressions, please.
Thank you, Uwe. That is a really good suggestion. And here in the Danish Society, we have early on this spring, we had a conversation about kindness. And I also think there is something about learning and using kindness in a systematic way, because it is very important to be kind when you are meeting the healthcare system. So how do we do that? And that is also, of course, one of the big questions. But yeah, I just here at the end want to thank Camilla for your great presentation and your excellent suggestions, and also to Ove, my good colleague. And I hope that everybody who has listened to this session today will participate in August at our facilitated live session, where we will, all of us, be together and answer questions and discuss this subject. So thank you everybody for listening, and thank you to the panel today. We will see you soon again. Thank you.
Thank you.
Thank you.